السلام عليكم. بسم الله الرحمن الرحيم. نبدأ النهارده. Good afternoon, esteemed doctors. It is truly our honor to have you with us today. On behalf of Organon, I warmly welcome you all to our launch event. At Organon, our vision is simple: a better and healthier every day for every woman. We are a global healthcare company committed to building a world where women, the backbone of every thriving and resilient society, have access to the health solutions they need and deserve. We strive to address health conditions that are unique to women or those that impact them differently or disproportionately. Through our diverse portfolio and in collaboration with like-minded partners and innovators. Often misunderstood, migraine can be a disabling condition that disproportionately impacts women. Studies have shown that the risk of migraine is more than 3 times higher for women than men. And the attacks tend to last longer in women than men, almost 37 hours versus 28 hours. In the Middle East and North Africa, headache disorders are the third leading cause of disability, and the migraine specifically ranked fifth. Today, we have an exciting lineup of topics and esteemed speakers who will provide valuable insights into various aspects of migraine. We'll take the chance to explore the profound impact of migraine on her quality of life and the burden of disease. We will also delve into the most significant breakthroughs in headache research from 2024, shedding light on the possible future of migraine care. These insights will provide a comprehensive view of the present and the future landscape of migraine management, inspiring us to make a significant difference in the lives of those affected. In addition to gaining valuable knowledge, today's event also serves as a platform for meaningful networking and collaboration. We look forward to your active participation as your insights and engagement will play a vital role in advancing migraine care here in Saudi Arabia. At Organon, we remain committed to delivering impactful solutions for healthier every day and to building a future where all migraine patients are empowered to better manage their health. Thank you once again for being here with us today. And now, without further ado, I invite you to watch a short video on how some women suffering with migraine have been misdiagnosed for years.
Maybe you're just stressed.
Maybe you ate something.
Have you tried drinking water?
Maybe it's your sinus acting up again.
Maybe you're just being dramatic.
For centuries, women's migraine symptoms were called anything but a migraine, affecting their quality of life and adding to the disease burden. Let's start calling migraines by their name, so there are fewer misdiagnoses and less suffering.
Thank you. I will invite Dr. Abdelrazak Al-Bilali. Dr. Abdelrazak is Assistant Professor and Neurology Consultant and Headache Specialist at King Saud University Medical City. Welcome, Doctor.
Thank you very much, Mohammed. Assalamu alaikum jami'an. Good afternoon, everyone. It's my pleasure to be here with all my colleagues, especially on Friday. So thank you very much for being here. Also, it's our honor to have Dr. Patricia Pozorosic coming from Spain. So Patricia has been with us. I remember during the first launch, or even before the launch, Patricia gave us so many talks and presentation emphasizing on the burden of migraine and the new treatments. So special thanks to Patricia for being with us in this journey. So the video is very inspiring and my talk will be aligned somehow. I don't want to steal the shine from Patricia. I'll try to make my talk short, but at least to emphasize on still an issue that we still have in migraine. So let me give you a quick, let's say, what is the status now about migraine in Saudi Arabia? So I call it the landscape of migraine in Saudi Arabia. This is my disclosures, but the slides is being prepared by myself, so this is my slides. So what does migraine look like now in Saudi Arabia? Now you could talk about it in the form of like number of headache clinics, number of specialists, and so forth. But I thought just talk about what is the prevalence of migraine in Saudi Arabia compared to the global, and is there a burden? Is there any need for these treatments, or is just adding more stuff that we don't need in the market? Now, before we talk about the local data, because you have to compare it with the global to say if we have higher prevalence or lower prevalence. If you have a very low prevalence, then there is no need for treatment. So let's start with, so one of the most well-known, I would say, institute who always look at the prevalence and the burden, and they usually have their famous popular reports. It's the IHME, and they usually publish it in the Lancet. And I think the most updated one was back in 2019 or 21, the report. But I will share a few data from 2017, which is very similar. I wouldn't expect any huge changes within a few years. But you can see here, migraine, looking at the most global prevalence of the 50 most common medical condition, you see migraine. Sorry, the laser is a little bit tiny here. I don't know if you see it. Migraine is the third. So headache disorders is the second. Including tension type headache and migraine. And you see the global prevalence is almost 15, just below 15%. And it's considered, this is high, relatively high. This is in the global level, at the global level. Dr. Steiner, Timothy Steiner, who has also been working with us at King Abdulaziz Medical City and also King Abdullah Research Centers, also focused on the disability from migraine, and he has done further many studies in different regions, including our region. And also from his paper, you can see here the top level 4 causes of global disability. We're talking about disability. And you can see for both gender, not just for female, migraine is number 2. So number 1 is low back pain, and migraine number 2. Now for female, above the age of 50, migraine is number 1 cause of disability. So if you see any female in your clinic less than 50, there is high chance that migraine is causing disability. So this is the global, basically, data. Let's look at the local data. So far, we haven't had so many data. We are still working to get a very good data, but we have an excellent, actually, paper, and research is being done by Dr. Al-Jum'a, Dr. Al-Khatami, in collaboration with Timothy Steiner, who did also publish the global data. This is by far the best methodologically and way of doing a study. We do have several papers that they looked at the prevalence, but they focus on one region, one city, one institute. This one by far measured prevalence across Saudi Arabia. And they have included above 2,000 patients. And you can see here the prevalence of migraine. This is Saudi population. The prevalence for both genders was close to 29%, which way above the global. Global is 15. So it seems the prevalence in Saudi Arabia is even higher. In terms of the age, specifically the highly active age population, the 36, 45, you can see they have the highest prevalence from all ages. Now, I just want to mention they did not include pediatric population, so this might make the prevalence a little bit exaggerated. If you include pediatric, it will be less, but definitely will still be higher than 15%. Now, the same group, Dr. Al-Jum'a and his colleagues, after 4 years, they published another study focusing on the burden. So the previous one measured the prevalence. Then in this study, they estimated the burden and the disability from migraine, and so they published this in 2024. The previous one, 2020, and they have used the scale called headache attributed loss time. So they give a patient questionnaire. The patient will ask how many days they missed school, how many days they missed work, and so forth, or social activities in a systematic way. And you can see here now, so they divided based on the diagnosis, so medication overuse headache, the 15 and plus, this is the chronic headache. And we think most likely 15 and plus chronic headache is most likely is what? Chronic what? I just want to draw your attention. So if someone has 15 days headache per month, would you think this patient is suffering from that headache? Do you think this is more like just a stress, tension headache, or it's a migraine? Most likely it's a chronic migraine. Now in this study they did not specify it, but we do think it's most likely it's reflecting a chronic migraine, because those patients, it said here, age 15 plus, it's headache on 15 or above days. And we know chronic migraine is more frequently captured in the clinic than tension type headache. So you can see here, so how many days they lost at work over the last 3 months. So patients with chronic migraine, they lost almost half month, like 15 days, plus or minus. So half month over the last 3 months from asking this question. What about lost household days, like at home, missing some work they have to do and so far, like taking care of children. So it's close to 14 days, just below 14, so it's another half month. What about social or leisure? Now, I also included a highlighted medication overuse headache. Medication overuse headache, we see it in which population of patients? Migraine, tension, cluster. It's more with migraine. So migraine patients, they are the one who has tendency, if they overuse abortive treatment, to develop medication overuse. Now, medication overuse head patient, they have higher disability, we think, than just having chronic migraine. So it's been included here. You see here, they lost almost close to 30 days, the month of household, and for the social also the close to 9 days. So it's still high burden. This is in Saudi, not global. This is here, like Saudi population. So you can see here, we can highlight and say with confidence that migraine is prevalent in Saudi Arabia, and it's not just a headache, and we shouldn't pay attention to it. Now let's move to what kind of the current treatment we have here in Saudi, like the paradigm of pharmacological treatment. Now migraine has different classes of treatment. There's non-pharmacological treatment, there's neuromodulation. I'll just focus on the pharmacological quickly. So it's mainly divided to abortive and prophylactic treatment. These classes of treatments, we all have them now in Saudi Arabia, in the market of Saudi Arabia. So it's good to be aware of them. And this is a beautiful illustration because at some point in the past, as you saw from the video, we used to explain migraine as a hysteria and all these things. Now we have a clear, and this is for you the beautiful transition from basic research, the translation of basic research to more clinical and real world. So here, this is the explanation how patients would develop migraine. This is part of the pathology. I wouldn't say everything. And here how the new treatments work on it. So patients who develop migraine, we know calcitonin gene-related peptide, CGRP, neuropeptide play an important role in transmitting the pain, especially from the nerve endings of the trigeminal nerve back to the trigeminal ganglion and all the way to the somatosensory areas. But the way how it works, so all this development targeted this pathophysiology. And now we have a monoclonal like galcanezumab binding to the CGRP. And data showed and trials showed, and also now, because we've been using it for many years, that it works. The same thing for GPAN is, or the other monoclonal can bind to the USP. So I just want to show you, this is how we can explain migraine also in a scientific way. Now, the last thing I want to talk to you here is we do have a consistency in terms of a guideline nowadays. In the past, especially at the beginning when we started to use monoclonal, there has been some sort of, I would say, different opinion when to use it, first line, after failing so many treatments and so forth. But at least in 2025, there are 4 international headache society have very clear agreement of using these treatments, because now and then we get some sort of a weird kind of opinion guideline that it says something totally different, unfortunately. So for the International Headache Society, they published their guideline back in 2024, and Patricia was with them, of course. And I just picked one of the questions to highlight the importance of using this. So question 9, they said, which preventive medication is suggested for people with chronic migraine? So if I have a resident who's doing an exam, written exam, board exam, and I put this question, they have to answer it similar to this. They shouldn't come with a different kind of way because they think it's all sinusitis or it's just psychological. They have to put it this way. So clearly they mention, we suggest atogepant, like explicitly put the names. So there wouldn't be any misunderstanding how to, they put the name of these CGRP target therapies, so atogepant, erenumab, tenozumab, fremanezumab, and also botulinum toxin A. Now, the international, they care about different countries. So some countries, they might not have these treatments. So what they have in terms of answer, they have the optimal option. If you have these treatments, use them. If you are in a place where you don't have them, then you could use topiramate, and they mentioned the others, amitriptyline beta blocker, thinking that, you know, most of the countries, they would have these things. But optimal situation, you need to consider these treatments. Now, and I'll show you in the other guideline, for example, the European Headache Federation, they were the first to update their guideline and to state clearly that you have to integrate monoclonal antibodies and the GPAN at the first line. You don't have to use it as first line, but should be option for the patient. And I'll just quickly go through the important questions. So they said, an individual with episodic migraine, would you use the CGRP targeted therapy? And the question here clearly, that individual with episodic migraine, we recommend using, and they put the name, eptinezumab, erenumab, fremanezumab, and galcanezumab as preventive. What is, if someone asks you, what is the quality of that evidence? So it's stated clearly here, it's moderate to high. And the expert opinion of using of this statement is strong. It's not like weak, it's not conditional, it's a strong based on their experience. Moving to the chronic migraine, they also have the same exact statement. So using these treatments, they have a high or strong recommendation with moderate to high evidence. Now, moderate to high is similar to high because other, I will show you the Canadian also, they have a recent guideline, they put it as a high. Another question is, when should treatment with monoclonal antibody target treatment, CGRP targeting, be offered to individual with migraine? When? First line, second line. So and they clearly, as I said, they were the first guideline that clearly say it. It should be used, as you see here, as a first line treatment as an option. So if you see a patient who might not benefit from the oral treatment, the injection, and they think this is a good option, you should consider for those patients. American Headache Society guideline, I'm not going to go through it, but their title say it clearly. They said calcitonin gene-related peptide targeted therapies are first-line option for the preventive of migraine. And this is the updated statement or position statement. And this is published just last year. The Canadian came with this update. The Canadian guideline also is one of the best. Actually, during my training, I followed the Canadian guideline because I did my training there. And basically, this is the summary of the recommendation specifically for chronic migraine. The chronic migraine patient are the one who suffer more from migraine. They have more disability. And as you see here, all the CGRP targeted therapies have a strong recommendation with high quality, including the botulinum toxin A. Because sometimes people say botulinum toxin A has low, and this is not the time to talk about it, but I thought it's important to highlight it's also included. Oral treatment, for example, topiramate, has weak recommendation, although it did have a good trials, but we know from experience it has a high chance for side effects. In fact, it's not recommended for a female with childbearing age, so we do not recommend it as a first-line treatment. And also, personally, I rarely use it, just for a specific people, but I don't use it for, like in general, for migraine patient. So home message, so the first one, migraine is highly prevalent in Saudi Arabia. And this is the reason why everyone is excited when we have a new treatment, a new addition to migraine treatment list. The second important point, it's not just common. Sinusitis we consider is common. Dental caries is common. The problem with migraine, and this is the issue, is it's associated with high burden and disability. And also there is economical consequences. Patricia, she knows better than me in this, and she's done excellent actually work on this. But this is also another field we're trying to explore here in Saudi, like how much patients are losing also in terms of from economical direct costs and indirect costs. And the third point is there is consistency across scientific societies. So there is no, as far as I know, there hasn't been any kind of discrepancy, like one guideline will say don't use this treatment and another line will say that. And so I'm just highlighting this because, as I said, once in a while I hear from people asking me this, maybe this is different than us and so far, but this is what we have. It's clearly, there's consistency. In our region, we still have to do further research, as I said, to explore more the burden, the economical burden from migraine, and also to improve if we are coming also with a local guideline to make it more robust and also clear to help our decision makers and our patients. And this is my presentation. Thank you very much. So I think I'm going to introduce Dr. Patricia Pozorosic. I hope I'm saying it right. Patricia, as you know, she's a well-known international renowned headache specialist and also speakers. So whenever we go to different place, like the American Headache Society meeting, European, we always see her. And also we've been also happy with her publication. I always follow it because it's really touched the importance of what patient needs. And also we are also thinking doing some sort of research collaboration. This is just from my part. But Dr. Patricia is well known. She's from Barcelona. We call it Barcelona here in Saudi. Barcelona. I think everyone knows Patricia. I will not waste her time with these talking. Your talk is about breakthrough in headache research. Amazing. I didn't know it will be about research. Well, that's great. Okay, so welcome, Patricia. It's great to have you.
Thank you. Thank you, Professor. And thank you. First of all, I wanted, thank you for the kind introduction. And I also wanted to thank Organon for bringing me again here to Riyadh. It's always nice to share what we do in headache with all of you. You're all very welcoming. I'm very lucky that everyone took their free day. I know it's a holiday for you today. It's Friday. And you all came to see me. I'm not sure if this would have happened in a Sunday in Spain, if the room would have been so full. So I thank you for taking time off from your families and from your leisure time, your relaxed time to come over and hear me and hear us, try to share with you new things. I hope that you will go home happy that you made the effort to come. And because yes, I will share with you new things that I hope will be inspiring for you. Okay, so this is kind of a disclaimer. So Organon, well, in that case, I just in relation to this slide, I want to say that Organon allowed me to present to you kind of what I wanted, which is nice when you want to do what you want, like me. These are my disclosures. Okay. So this year, I was honored to be invited by The Lancet to write the editorial that summarizes, in my case, headache research in 2024. The Lancet, every month of January, publishes editorials from all of the different specialties, summarizing what has happened or what happened a year before. So during the month of December, I had to sit down with my computer and myself and think what I thought was or were the big advancements in headache research that had happened in 2024. And I chose, there's a limited space, you cannot choose everything. So I chose 5 different things. But the number one thing that it was clear in my mind that I wanted to highlight in relation to what had happened different and new and special in 2024 was that migraine prevention treatment should be started earlier. So not only, as it was just mentioned, migraine is a prevalent public health disease, very burdensome, that creates a huge amount of disability. Not only we have nowadays anti-CGRP therapies, which are very effective. It's a way to summarize it. This means that the efficacy of the drug is good, that the tolerability of the drug is good, and the safety of the drug is good. But there is an extra point that we are starting to realize in the migraine field, is that most of our patients are misdiagnosed, as we were just seeing, but have access to treatment too late in time. And why do we have this, or where does this knowledge come from? Well, for us neurologists, I don't think this is kind of a new message. When I was a resident more than 25 years ago, I participated in the ECAS studies. Those were the studies done in Europe to approve RTPA in the treatment of stroke. It was magical to be on call. I remember still those nights. And we, calculated the dose and we put RTPA. It was the first cases that were treated. And suddenly, magically, many patients kind of recovered. But it was also clear that if we didn't treat patients in the window, the therapeutic window, we had issues. We had problems, and there were consequences to that, like brain bleeding or something that then,
فصل النت. ليش فصل النت؟
Recording in progress.
machine inside of the ambulance so that you can already diagnose the patients while you're moving towards the hospital. So yes, we know this has happened. And as I said, this is something that for you is not new. Is it happening also in other neurology fields? Yes, the answer is yes. In the middle of the slide, you have what I consider is the equivalent paper, but for multiple sclerosis. Actually, in my hospital, at the Vall d'Hebron Hospital, we have a very, very well-known multiple sclerosis center group that has been studying multiple sclerosis for the last 30 to 35 years. Perhaps you know Xavier Montalban. He comes sometimes invited here to the Menactrims. So he was the last author of this paper, which clearly has identified that just by delaying in days and probably hours. I mean, since the first symptom of the first bout of your multiple sclerosis diagnosis, you condition the future midterm and long-term outcome of that patient. So that is something that is already starting also to permeate. Can we wait for weeks before starting treatment? Well, you better not. If you have an optic neuritis, start treatment, specific, targeted, multiple sclerosis treatment as soon as you can. Do we have even more data in the neurology field that time is brain? Indeed, Alzheimer. Alzheimer has been pouring amounts of money in research for the last 40 years. And only recently, I mean, we do have donepezil, memantine, and other drugs that help patients. However, only recently we are really kind of achieving success with the treatments that are being currently developed and approved, such as lecanemab and donanemab. Probably have heard of them. But what was the challenge there? That when we did all those trials, 20 years ago even, or 10 years ago, patients didn't improve really. We weren't able to change the course of the disease. It was too late. That's what we realized now. So what has the field done? It has created biomarkers to understand how can we diagnose patients even with preclinical symptoms of Alzheimer. Because if not, it's too late. We cannot change the course of the disease. So we also are understanding that in order to try to control a little, modulate, prevent neurodegenerative diseases, we have to start treatment early. That goes very much in hand too with the development of biomarkers. Biomarkers usually in the field of the brain have to do with either imaging or molecular biomarkers. And in migraine, we are also working on finding the right biomarkers. There are hints that structural imaging is different. And actually, with artificial intelligence, you can, you call this deep learning. So with deep learning, you can actually differentiate in an unbiased way, not by a person, the brain of a migraine person with a brain that is, let's say, a controlled brain with a 75 to 80% specificity and sensitivity, which means really that it is quite, evident for the machine that the migraine brain is different from the other brains. And even chronic migraine is even easier for the machine to perceive and see. And we are starting also to develop molecular biomarkers. Probably in the future, I will see it before I retire, so you will all see it too. We will have molecular biomarkers for migraine, maybe CGRP, maybe PACAP, maybe epigenetic also, my biomarkers, DNA methylation. You'll see certain things that are going to come to the field, which will be very interesting. And these are also happening, in other parts of neurology. So why should migraine be different? Migraine, in my mind, is not different. But for the first time in 2024, we are starting to have evidence that we should be treating also migraine. The sooner the better, or the earlier the better. We already knew this in migraine from attack treatment. You have educated, I am sure, many of your patients to take triptans within the therapeutic window before central sensitization develops. Because if not, if you take the triptan too late and patients know it, then things don't work as well, and they are burdened by the 2 or 3 days that the attack lasts for. So we were already doing a bit of that, but we didn't realize that that was kind of preventing the progression of the disease because we didn't have probably the right treatments to allow us to realize that this was also a reality for migraine. So migraine, you might think, well, Patricia, no, I don't really agree with you because migraine is not a neurodegenerative disease. And actually, when you're 60 or 65, migraine improves. Well, I'm not too sure that happens. I'm going to put you an example of a paper that was published also in The Lancet, actually, but in the 1950s. The title of the paper was The Natural History of Migraine. You were just thinking that migraine improves because probably the misses stayed home at that time or didn't go too much to the doctor. But you had here a Mr. GB that starts really migraine in puberty. Well, that's quite typical. That, keeps on increasing. And there's different things in life that happen to him. theoretically, it's interesting to see this, he marries. Is this good or bad? It seems that his migraines don't improve with marriage. I mean, they just stay. He's a chronic migraine patient. And then in the 60s, when you expect the disease to improve, it says father died, but that's not a surprise. If you're 60, your father, usually dies when you're, the father probably was 85 at that time, so it was time to die, probably. But see, it's even worse when he's 60 years old. Many migraine patients do not improve. And if they do improve, maybe in the type of pain, migraine attacks keep on happening with auras and different things that are actually progressing, and creating an evolution that, if untreated, is uncontrollable in many, many patients from all of these 30, 25, 15. Put the percentage that you want, because it is a high percentage. So what are we seeing in 2024? For the first time, we have 2 or 3 important papers in my mind that are teaching us that if migraine patients are treated earlier within the evolution of their disease, the outcomes are better. One of them was the APPRAISE trial, published in JAMA Neurology. The first paper where we actually treated patients either with erenumab or standard oral of care. And we saw that if you had the choice of either giving in a randomized way erenumab, so an anti-CGRP therapy, or standard oral of care, those patients treated with specific therapies, anti-CGRP therapies, did better. So it tells you that if you treat earlier with specific therapies, your patients will actually have better outcomes. That's already something important to understand. Moreover, we published also the largest real-world anti-CGRP paper. This was a consortium. We called it the Eureka Consortium, a European consortium where we included almost 6,000 patients. This was led by us at the Vall d'Hebron University Hospital in Barcelona. And actually, you know what was our initial hypothesis? We thought that we really wanted to collect a lot of data because we wanted to see if there were different responses in males and females. We thought if we have a lot of patients in there, perhaps we see that there's a difference there because we think that migraine might also have some type of hormonal component. And we did not find anything, similar to that. Males and females respond equally. But we did find that a good predictor of a good outcome of response was to be treated earlier within the disease evolution. This means that if we were treating patients who had medium or high frequent episodic migraine, their odds, so the possibilities of them responding with a 50% or more of response were much higher than if they had chronic migraine. So if you treat your patients when they have chronic migraine, they can respond, but the chances of being a 50% responder or more are less. So it is clear in my mind that we have to treat patients earlier if we want them to respond nicely. More data that was also published in 2024. Germany. We go now to Germany. In Germany, the government, when you have a new treatment coming to the market, they put it in the last line of therapy. So when anti-CGRP therapies were launched, they were number 7 in the line. Number 1, number 2, number 7. Imagine you had to wait perhaps 7 years before getting treated. So this trial called the Hermes trial was done, and it compared, in this case, erenumab again, because it was the first one launched, against topiramate. And they found that patients responded, as we were seeing and we know nowadays, that patients responded better if they were with topiramate than with erenumab than with topiramate. So quickly, the Germans are very, they work like strong machines. I mean, they have rules and regulations that are followed. That's how Germans are. So they quickly change the regulation. If we say we change it, we change it. And they change it immediately. And the Berlin group, the headache Berlin research group, quickly published this paper in the Journal of Headache and Pain, showing that when you treat patients as 7th line, the chances of being a 50% responder or more are around a 40%. However, when you start treating patients as 1st line, the chances move from 40 to 60%. So treating patients earlier with the right specific targeted therapies developed for migraine is better for your patients. And if it's better for your patients, it makes all of you a better doctor. Patients will be happier and will come back, with more patients. So if you want to make money, it's certainly a money machine nowadays, because you really help patients. And as it was already mentioned, this immediately also created an update to all of the recommendations, consensus statements, and guidelines from the different societies, positioning anti-CGRP therapies as first line. So what other early things then do we have to do? So it's early within what? The next then challenge is how are we going to make sure that patients don't wait 5 to 10 years to get diagnosed and another 5 to 10 years to get treated appropriately? That's a lot of years. So what can we do to try and organize our patients' journeys? And it has to move from this chaotic thing that patients try because they go to doctors and they don't feel listened to, they don't feel understood, they don't feel that they are receiving the right treatments, and that creates, kind of, they are not, they don't feel well, they don't feel happy, they complain. So I kind of think that here also this is what we are trying to do back in Spain, but here I think we should also try to design, you would say, this patient pathway to understand what are the steps that the patient takes before getting to the right doctor and the right treatment in order to see how then you can accelerate. So analysis first, understanding, kind of listening, to the picture that you have, and then trying to make sure that you can accelerate the pathway in order to get the right treatment. And this is, as it was already mentioned, important because we are starting this problem in the teenage years. And I don't know if here, but in Spain, the teenage years are quite an orphan age. What happens when you're a teenager? You don't want to listen to your parents. You're tired of your parents. You want to create your own identity, your own personality. And you break a little with kind of what is, the good things that your parents have told you about. And that's a problem because teenagers often don't seek for help. And we have to try and address the problem when it's starting if we really want to make a change in the evolution and the disease evolution of migraine and create campaigns, public awareness. Because on top of it, if you treat chronic migraine patients, this is another paper that was published this year, where us, the International Headache Society, have set what we think are the goals for excellent care. It's not good enough if you are treating a patient that has 20 migraine days per month and you improve a 50 or a 70% and you go down to 7 days per month, which is much better than having 20 days. Patients will be happy, but it is not really controlling in an optimal way the disease. You have to go down. And you could. And if you could, if you do it early enough. So in order to accommodate what we believe as experts that we should be offering patients, we have, again, to start treatments early or earlier. And I do believe, as it was already mentioned, that you have a challenge here also, like in every country in Saudi Arabia. I've heard, it's been said that you are 35 million here. It's a very large number. There's a lot of Saudis. And that, without exaggerating and putting a 30% of patients, let's say a 10, let's lower it down. So at least there are 3 million or 3.5 million migraine patients around, at least. But you can, according to what was just presented, you can multiply this by 3 even. And I've heard, but maybe I'm wrong, that you're around 500 neurologists. So I can tell you have a lot of work. You have a lot of work. You have to, in order to, do things right, you have to organize yourselves and you have to try and pick the patients early when the disease is starting. And then women, and men, when they become older, won't be patients. Maybe we will be able to even avoid chronic migraine in the future. And you might say, well, yes, but no, because not everyone responds to anti-CGRP therapies. And you would be right, but you would be helping at least around 70% of your patients. It's a lot. It's quite a lot. I mean, of course, things could be better, but it's better than nothing. So knowing that this is the reality of 2024, we have this information. You already have the data of what is the reality in Saudi Arabia. I come with good news because I have tried to think with you and for you, and we can do this exercise together later also with the question and answers on what could be 4 different ideas, 4 different tips to try and overcome this challenge. How can we do this? What are the issues? What do we have to think of? And these 4 ideas that you see on the slide, I'm going to talk about each one of them. But I have to say that they, kind of the solution to our problem and our patient's problem didn't really come from me. I got inspired by someone who is quite well known. And I know that also here in Saudi Arabia, you like sports a lot too. You have Cristiano Ronaldo now playing around soccer. There is another very important tennis player, or sportsman. Do you know who he is? Before I say his yes, have you recognized him? But just in case you don't follow tennis, he's Swiss. His name is Roger Federer. He was the number one tennis player for many years, and his style of playing tennis was very elegant. Very elegant. I mean, Roger, you can check a video if you go back home today and see how, for example, he really won, I think it was 7 or 8 times in a row, Wimbledon. His favorite court and tournament was Wimbledon. You probably also are aware that that is played in London. It's a very green country with a lot of rain. So that's Roger. Roger retired recently, maybe I think it was probably 2-3 years ago. And nowadays he has many objectives in his life. But of course, as being a well-known person that has had a lot of success with a very full life already, being number one and keeping it for such a long time is not easy. So he's invited to give different speeches. And I found this one by chance. He was invited to do what is called the commencement speech, which is when in college, so in university in the United States, you end up the 4 years of college, and then they do this graduation, the class graduates, and they usually do this commencement where they invite a speaker. In this case, Roger was invited to Dartmouth College. Dartmouth is in the northeast of the United States, also very green, as you'll see. It's raining, so very British, the whole thing. And I chose these 4 ideas, these 4 excerpts of the video, in order to try and see whether if what Roger did to become a number one tennis player could help us become number one migraine doctors for our patients. So let's hear his first idea. We don't hear the video? Can we hear the video? I'll start again. You want to try? No. Well, I can, I know what he says. I can translate, Is it going to work or? Well, what he says in this video is that effortless is a myth. What does he really say? He says that his play seemed effortless because, as I said to you, he was very, very elegant. So he says, this really bothered me because I had to put so many hours, so much effort to make, to win, to make my play effortless. I had to put a lot of effort. So really, if you want to have success, if you to be a number one, you have to put an effort. And you all know that. How many hours have you done, studying to become a physician? In Spain, it's 12 years, more or less. 12 years. Physicians, we know we have to put effort to do things. But sometimes we forget that we have to do an extra step when really it comes to helping patients, because sometimes the system doesn't help us help them. So we have to try and make an effort to understand what the system has in order to change the system and try to really provide care when patients really need it. Okay? Do you want me to try again or? Not sure. Well, like I'll try one more time. Let's see. Because there are 4 videos, so
Effortless
Okay.
is a myth. I mean it. I say that as someone who has heard that word a lot. Effortless. People would say my play was effortless. Most of the time, they meant it as a compliment. But it used to frustrate me when they would say he barely broke a sweat, or he's even trying. The truth is, I had to work very hard to make it look easy.
Exactly. We all work very hard to make it look easy. That's what elegance is about. That's why his play was elegant. But he put many hours behind it. And as I said, we do too. So what should we do? What type of efforts I think need to be done? Now that we have the right treatments, we know they have to be given early in time. So what would be the next step? In my mind, we have to work the headache clinical care pathway. We've tried this and published it, so you can maybe see whether if it's similar or not, but if not, analyze it locally. This is something that cannot be done globally. It has to be done in a local way. And we also published the barriers that we were seeing in our country, in Spain, to provide good healthcare, good migraine healthcare for our patients. So try you should try to analyze this. Second thing, which was already mentioned, try to see something, at least in our government, we have public healthcare, and anti-CGRP therapies are fully reimbursed in Spain. So it was very hard to convince our government to do that. And in order to do that, we had to do our homework. And our homework was to demonstrate what were the costs of migraine. And we have worked around this through several papers. This was the first one. In this paper, what we showed in a survey, which was done at a population, web-based, and quite easy, you could do it yourselves too. What we found was that if we reduced 1 migraine day per month, so 12 days per year, we were already saving money. And if we reduced 50% or more of days, we were reducing even more money. So it looked like, for the numbers that we managed in Spain, that the amount of euros that we were saving was economically reasonable. We also have done the same kind of study, but using even more specific scoring systems or scales to try and capture the work productivity, absenteeism, presenteeism with our own cohort of patients who were started on treatment with anti-CGRP therapies. And this was published last year in the Journal of Headache Campaign. And what we saw was that we were already saving money at 3 months with patients. And we did another study in our hospital. I work in the largest public and private, and in the largest hospital in Spain. It's a big university hospital with more than 10,000 employees. And one day we thought, why don't we actually survey our employees to see how many have migraine and what are the resources that they are using from the hospital. So these are costs that are related directly to the hospital. And what we found was that the costs of our migraine population in the hospital added up to around almost €500,000 per month. From these, 150,000 euros were not indirect, but direct cost. These are the most important costs that worry governments, that worry healthcare providers, insurances, because these are costs that you cannot kind of take away. So I went back to the director of the hospital and I told him, listen, if you would invest a bit in migraine, you would be saving all of this money. How many drugs can you pay with all of this money? A lot, I can tell you. You can even pay physicians to become migraine, and treat migraine patients. So there is a lot of money to be saved or invested, you would say, if you really address with some effort some numbers that will help you change the patient pathway and make sure that you will be able to start treatments early. What's the second idea that I took from Roger? Go for your strength. Let's see what he did.
When my self-belief really kicked in, I was at the ATP finals where only the best 8 players qualify. And I beat some of the top players I really, really admired by aiming right at their strength. Before, I would run away from their strength. The guy had a strong forehand. I would try to hit his backhand. But now I would try to go after his forehand. I tried to beat the baseliners from the baseline. I tried to beat the attackers by attacking. I tried to beat the net rushers from the net. I took a chance by doing that. So why did I do it? To amplify my game and expand my options. You need a whole arsenal of strength. So if one of them breaks down, you've got something left.
Yeah. Have you ever done that in your lives? Have you ever done it? Think about what he's saying. It's actually very interesting. I'm not sure how many of you play sports, but let's say that we are playing tennis. Let's put ourselves in Roger's shoes. If I'm a tennis player, I play against one person, and I know that the other person has a very good, let's say, forehand and a very bad backhand, or worse. Where would you throw him the balls? You would throw the balls to his backhand. Yeah. And if I am a very good, also, let's say, forehand player, when the ball comes to me, I would move quickly to try and hit the ball with my forehand all the time and avoid the maximum possible my backhand, because I might then not lose the point. I mean, I might lose the point. So this is what we all naturally do. If we feel good with something and we think we are strong in that, part, we amplify. I mean, we do it more, forgetting a bit kind of the part of our kind of, you can call it whatever, strength or intelligence or whatever you want to say. I mean, and in life, our tendency is to try and make our life in a way easier, just projecting our strength in a way. But in order to really become strong, what he's saying is very powerful, which is what you really have to do is work on your weaknesses. If you work on your strengths, I mean, that is easy. So work on your weaknesses to amplify the game and make sure that you will be prepared for anything in life. So kind of be brave, And you're like, okay, Patricia, so why is that important for migraine or for me as a physician? Why do I need to amplify my game? Well, first of all, you need to amplify your game because it makes you a better doctor, that's for sure. And don't avoid certain situations or certain patients. It makes you a better doctor. Amplify your game. So think of treating maybe, migraine. And what is our strength? So our game has been clearly amplified by these anti-CGRP therapies. They're all plotted in this figure, all the phase 3 clinical trials. And we have a very powerful already strength because all of these treatments are quite, similar. Imagine that one of them would have not functioned or worked. That would have kind of killed the class. So no, the class is a solid class. It's a class that provides care, good treatment for the patients. It actually works very nicely. We've been doing it for the last years. But not only that, amplify your strength by using the class and using it early. Do something that is harder for you, and you will realize and feel better with yourselves by amplifying the game, I am sure. But it is not natural. Okay, third idea from Roger.
Tennis, like life, is a team sport. Yes, you stand alone on your side of the net, but your success depends on your team, your coaches, your teammates, even your rivals. All these influences help you to make you who you are.
Exactly. So, my question to you is, do you work as a team? Do we work as a team, physicians? Are we used to working as teams? Not always. That would be my answer. When do we work as a team? Number one, any ideas? Okay, I'll say it. Don't worry. I won't put you on the spot. The OR. Surgeons are used to working in teams. They know that they need their nurse, they need another physician there, they need the anesthesiologist. They understand they have to work in a team. Yes. Who's a surgeon here? No one. No one is a surgeon. It's not a surgical topic, migraine. Okay. So next, maybe, hospitalized patients. Oh, yes, we need a nurse there also. Yeah, that's part of the team. You meet with them every morning. Yes, of course. We work a bit as a team. But where do we see our migraine patients? In an outpatient clinic. 1-to-1, face-to-face. It's like a tennis game. And Roger says that if you want to be very good, you have to work as a team. Team member number one, your patient. Create a team with them. They're not the opponent. You're not just someone, very special and they're not, create teams with your patients, create teams with nurses. The biggest thing that happened in my life, well, nowadays I have a headache team. We are 5, 6 neurologists and we have 2 nurses. The best thing in my life was to introduce a nurse in my team. That changed my life completely. It is such a joy. Patients love nurses. Love them. So create teams because you're going to increase the impact that you're going to have as a physician. Don't worry. You can share. I share all of my knowledge, the tips that I do. You're all welcome to see how we are organized in Spain. I don't mind sharing every tip and trick that I do. And you know why? Because there's so many patients out there. There's 7,000 patients for each one of you. Don't worry. You can all be good doctors. You don't have to be the special one for migraine. It's not a rare disease. So whatever you do can be helpful for everyone. Share knowledge, work together. There's no problem with that. So remember that patients are also very, very important, that we can work with different types of healthcare providers, and all of this communication, collaboration, and cooperation helps you feel better. You realize that you're doing and having a higher impact, and it helps patients, which is the most important thing that you can do. And finally, don't worry, I won't, I won't go on with many more ideas, but this is the last one, and I think probably the most important one.
Some defeats hurt more than others. I knew I would never get another shot at 6 in a row. I lost Wimbledon, I lost my #1 ranking, and suddenly people said, he had a great run. Is this the changing of the guard? But I knew what I had to do. Keep working and keep competing. In tennis, perfection is impossible. In the 1,526 singles matches I played in my career, I won almost 80% of those matches. Now, I have a question for you. What percentage of points do you think I won in those matches? Only 54%. In other words, even top-ranked tennis players win barely more than half of the points they play. When you lose every second point on average, you learn not to dwell on every shot.
Incredible, huh? Does that surprise you? This guy, who's #1, has been for many years, was #1. Think about the number. Let's see. If I would have a board here, I'm used to giving classes in the university. If I would have a board of paper, think about what he's saying. He's saying that in order to be a #1 player and win 80%, this doesn't, you don't see it. 80%, you only have to win 54% of all of the points you play. Only. With half of the points, but you have to win half of the points, which is hard, you will win the race. You will win the final race. I thought that was very interesting when I heard him say that. Why did I think that was very interesting? Because when anti-CGRP therapies were actually launched in Spain, I was called up by the government to try and explain the results of the phase 3 clinical trials. And you know what was the first criticism I heard? Patricia, only 50% of patients improve at 50%? Is that good enough? Oh, ask Roger. Now I would have said that. He thinks it's good enough because you help, and it's exactly the same number as 70 to 75% of patients. Do you realize? So by improving 50%, so when you are reaching these numbers, you're arriving, we are getting to being perfect. We are reaching, and yes, perfection is not possible, but we are reaching it. We are reaching success by helping more than a 50% of our patients achieve more than a 50% response. And that creates, if you think of all of the 100% patients that you will see, if you treat them with anti-CGRP therapies, you will be helping around 75% of them. Only 25% do not respond, more or less. Same numbers as Roger. So, perfection. Let's now concentrate a little on the galcanezumab data, and let's see whether if galcanezumab, for example, is perfect or not, and how imperfect it is. So what we see from the phase 3 clinical trial data, they were called the EVOLVE trials, 60% of patients achieved a 50% response of migraine or monthly headache days. So more than 50. We are better than Roger here, 62%, it's good. So what are we saying really? That you are helping a lot of patients achieve better outcomes. And for them, success, and you will realize when patients keep on coming back and thank you, because that's a nice thing about headache. They realize quickly they're improving and they come back saying, thank you, I am much better. My life is much better. Another criticism I found from authorities was saying, but the improvement in the number of days that are reduced is only 2 days, more or less. Is 2 days enough in a month? Yes, it is enough. It is enough to be almost perfect. Perfect for responders, but responders are quite many of your patients and will be quite many of your patients. Another important thing is that patients start responding on day 1 with Emgality, with galcanezumab. You start treatment, it's sub-Q, and it really kicks in already on day 1, and on the first week they're starting to notice it. The full effect, as far as we are realizing from real-world data and the clinical trials, is that you probably reach the maximum effect at month 6, so between months 5 and 6. And then you sustain the response. We will see data of more than 3, 6, and even 12 or 24 months. We are starting to have and collect large numbers of this data. You see here, for example, this comes from the open label extension phase of the trial. And once a patient responds already on month 1, it keeps on improving slightly. You see that the line keeps on going down until more or less month 6, 7, and then it more or less flattens the curve. Patients who respond will keep on responding. That's good news for you and for your patients. Patients will suddenly not complain. And if you start treatment early, when patients have 5, 6 days, suddenly they go down to 2, 1 day of migraine, which is not as intense, not as severe. Patients very happy, very well controlled. This also happens with the chronic migraine patients, although it is a bit harder for them, to respond. I mean, the percentages of the odds of becoming a 50% responder are a bit less. With chronic migraine, we kind of, in a way, because we have no other options nowadays, we lower a bit the threshold. We are happy if they respond 30 or more %, but they can also respond at 50. It's not that it is impossible, just a bit harder. If you're a refractory patient already, because you have tried many other treatments, those treatments, galcanezumab included, also improves it. I mean, you can be a responder, and there's a significant improvement in the burden in between attacks. Patients stop having anticipatory anxiety for the next attack. They start telling you that they don't need to use as many triptans as they were using before. They can use NSAIDs, other types of drugs, and with less amount of pills per attack. So that's important. And we move from the phase 3 clinical trials with galcanezumab to the real-world evidence. And in real-world, galcanezumab has already published data from Spain, the GALCA-only trial or study, the ORIGAM study. We have data coming from Italy. The Italians are very fast. I mean, they're very hard-working, the Italians, at least in the headache field. And they published the GARLIT study. And the other one, I can't remember the name, GARLIT for sure, and another one. So we have data coming from real world. We have our Eureka Consortium paper, but specifically, galcanezumab also has the TRIUMPH study, which is a study that was done at an international level, not in one country and not in Europe. And you have a bit of the US, you have in Europe, the UK, Germany, Spain, and Italy. You have the UAE here in the Middle East, and also Japan in Asia, which I think will be nice when the full cohort will be analyzed. For now, what I'm going to share with you are the interim results of this trial. And it's actually a very complete trial. It follows patients for at least 2 years, and patients can receive either galcanezumab or traditional oral migraine medications. The cohort of patients included and analyzed for now shows us that patients are still arriving too late and in a high burden state of migraine. So the mean monthly migraine days of patients included was around 14. Most of them had chronic migraine, again, telling us that we are arriving too late, 72%, and with high MIDAS scores, so very disabled already. Most of them were women, included with a mean age of 45. This is because we are getting there too late. We should be treating these patients much earlier. And well, in my mind, it's a pity. It's up to us to change this reality. And the good news is that this looks very much like the APPRAISE trial that I was mentioning. The first thing is that patients clearly respond much better if they were treated with galcanezumab than with the traditional oral migraine preventive medications. This is not placebo. I mean, the other arm. The other arm are the rest of medications. It could either be tricyclic antidepressants, valproate, topiramate, beta blockers, flunarizine. They are not better clearly than galcanezumab. Here we are. Okay. I don't know what happened. Then when migraine monthly days or headache monthly days improve, that correlates immediately with a reduced use of acute medication in the number of pills, and as I was saying, the type of medication. And that has an impact on an improvement in the disability, in the burden. It increases quality of life, and patients go back to work. As you can see, the green line, which represents galcanezumab, clearly is different in this chart because the amount of work lost or increased work productivity is much less in comparison to patients who were treated in this trial with other CGRP antibodies even, and also there were some patients included with Botox. We will have fuller data. This data comes from around 2,500 patients, which is a lot, but the full cohort of the TRIUMPH study, when it will be published, will round up to around 4,000 patients. So it will be interesting to see the full-blown analysis, the full data cohort. So everything kind of improves when you treat patients right, and we are proving this also at a clinical trial level, and at a real-world level, also with galcanezumab. So to sum up, I would say that Emgality, galcanezumab, is quick and consistent, and we have all of the data that show us it's reliable, it improves the quality of life of our patients, that that there's a loading dose, and that was done because it was seen that in order to get a steady concentration after a first dose, and in order for it to be really kicking quickly, it was better to do this on the first month, but then you have the 120 milligrams sub-Q dose every month, and that's important. And that it is the efficacy and in real world the effectiveness of galcanezumab works for episodic, for chronic migraine patients, and for those who have been already treated with previous migraine preventive medications and that are considered to be refractory or treatment-resistant patients. And that already from the first dose, there's an early and sustained effect. So really, I think that we have a good drug, and especially I hope that this talk will have inspired you as it inspired me to hear Roger, in order to change the reality of migraine care here in Saudi Arabia, in order to make your society, because this is a public healthcare problem, a happier society. So thank you.
Thank you so much, Patricia. It was a great talk, very insightful, and I really like combining some, I would say, suggestion or insights from someone outside the field, and combine it with what we are doing. Let me just look at the setting here. So we have people
Online,
connecting online. Okay. Okay, so should we, do I need to monitor something or? Okay.
For the online questions.
Very good.
And of course, we have our team for if anyone has a question.
Sure. So let's start here first. Dr. Bakhit, you have, do they have the mic, the audience? There's a mic, yeah.
Thank you very much, Patricia. Thank you, Dr. Bilali, for this informative talk. My question just regarding early treatment.
Mm.
When we talk about stroke and MS and Alzheimer disease, the etiology is almost a lot of work has been done. In stroke, you have a blockage. When you remove, you will have a good. In MS, we have many biomarkers. We have CSF.
You don't have that many, eh? In
And,
effect.
yeah, in
Yes.
Alzheimer,
Some.
but in migraine, still we depend on history.
Mm.
We have no good information from MRI.
Mm.
We have no biomarkers that we can say.
Mm.
Still, we don't know that CGRB is the main causative.
Mm.
Still, we don't
It's
know.
one of them, yeah.
Still, we don't know is it neurodegenerative disease or not.
Mm.
So when you put this in mind, and we don't know the long-term effect of anti-CGRB, is it side effect? Is it prolonged blockage of CGRB may cause? So a lot of questions to come in mind. So when you say that early treatment, still we have no. You understand my question?
Yes, yes. I think that I understand, of course, your question because I know that I'm being provocative, but I think we have more data than the one you say. First of all, okay, anti-CGRP therapies. They're really, they've been, so the first trials that we did, at least in my center, were in 2015. So it's already been 10 years. There's, modern medicine doesn't have, that much good data. In my mind, it is very clear that I think that topiramate is a terrible drug, personally. So we are starting to see data from the drugs that we usually, treated our patients with. So, yes, we don't have 20-year data. We are starting to have 5-year data. We are starting to have 10-year data. Maybe it's not, good enough, but it is better than what we had before. And I think, probably it will be fine. But of course, I don't know, and you don't know either. I mean, we all don't know. That's one kind of part of the answer. So yes, maybe it's risky, but I don't think that topiramate, is better. What would be the other option? Giving high doses, 120 milligrams of propanolol, not tolerable. So I'm not sure we have another option. That's number one. Number two, in regards to having or not information that this disease for some patients progresses, I think we have clinical information. You all have, at least I have. And if you see enough patients, you have patients that are 60, 70, 75, 80. I mean, I don't know here until when they live. Spain has very high longevity together with Japan as a country. So people in our country live for many years. And we have a lot of elderly patients. We actually published also our experience with anti-CGRP therapies in the elderly, you would say. And that's because we are not treating patients soon enough. It's quite clear in my mind. I have made it my life's mission to demonstrate that migraine will have and has biomarkers, and I'm sure I will be able to come back to Saudi to share this with you. But we are starting to see things like there is a recent paper published that associates migraine with Alzheimer. So I'm not too sure. It's the highest. Another paper written by Tobias Kurth et al. That shows that migraine is probably the most impactful cardiovascular risk factor. So probably if, we will see in the future with all of this epidemiology, but probably by treating migraine appropriately, you might be able even to control certain degeneration that might happen in your body at a vascular or cardiovascular level, maybe even for your Alzheimer. And clearly, for some patients, not everyone, of course, in migraine has the risk of becoming a chronic migraine patient. But for those who have, I am sure that, by treating this early, we will be able to avoid a percentage of it. And you're right, CGRP is not all of the story. It's not perfect. But as he was saying, perfection is not possible. We are getting there. Is amyloid the whole story? No, amyloid is not the whole story. Suddenly we find out there's tau. And I can tell you, it's not all about tau. There's many other things going on there. We are talking about the glymphatic system. We are talking about maybe other proteins that are there involved. So yes, why are we asking more about, for migraine than not? And in regards to blockage or blocking CGRP, we have proved by our CGRP analysis in saliva and serum that you don't block the whole thing. You block a part of what is probably being released at an extraordinarily during attacks, which means that all of us, whether if you have migraine or not, we all have CGRP in our bodies. But during migraine attacks, CGRP gets released much more. And what you do with these treatments is actually control probably this change, because we have measured CGRP in our patients before and after treatment, and there's still a lot of CGRP around, even when you are treating. CGRP acts, he showed one of the receptors. CGRP acts in many types of receptors. It's doing its actions through different ways. I always think that biology is very intelligent. It has a plan A, a plan B, a plan C. So when CGRP has to do its effect, it does it in many different ways. So I actually believe that we are not blocking completely CGRP in the system. We are blocking the part that is clinically relevant to control migraine for around 70% of patients. And half of those 70%, in those, let's say 40 or 35% of patients, CGRP is really one of the main drivers, because you have, and you will see if you treat enough patients, that some patients respond 100 or more than 75%. And for them, CGRP is the migraine molecule, but it doesn't, solve the whole 100%, that's for sure.
Oshik, go ahead. Yeah.
Thank you very much, Patricia, for this elegant and comprehensive talk. And thanks to Dr. Bilali, and thanks to Organon Saudi to give us this opportunity. My comment about migraine is, Bakhit spoke about what we call on the bench. I would like to challenge something on the clinic.
Mm-hmm.
I believe migraine is not one entity. People should not approach
agree.
patients with migraine as one group.
Yeah.
Migraine is a spectrum of diseases manifested by pain in the head.
Yeah.
And this pain has characteristics, and the International Headache Society gave criteria for diagnosis.
I agree.
But for a doctor to approach a patient, it is not one disease. And even in the same patient, it is not the same disease all through life.
I agree.
Patients with migraine, they do change as time goes on, and they can have also additional types of migraine. Some patients who have migraine tend up to have medication overuse headache, or they tend up to be migraine stops and they develop tension type headache. So I would like to bring people to the clinic. Always think about your patient who comes to you with a problem that needs handling, rather than telling them about surgery or advances in medicine. So I would bring people to history taking. Every patient coming with headache, don't think that this headache patient I'll see in 5 minutes while I'll see a patient with stroke for 1 hour. No, you should give the patient the utmost time and attention and listen to the details of the history and look also for the red flag symptoms and if the patient needs investigation or not. That's my first message. My question to you, which acute medication would you like to, on basis of the evidence base you have now, to recommend when you use Emgality? The patient still they can get attacks, but might be milder, maybe less frequent, maybe duration shorter.
Yeah.
Which probably I would say a drug that can enhance the effect or probably be best choice. Because many patients ask us, what shall I use? I give them NSAIDs, but I want to know your experience. Second is, how long will you treat a patient with Emgality, particularly if they are thinking to get pregnant? Because we know migraine disease of young females in childbearing age, and there's always a question, I want to get married, I want to get children, and you say you have to stop taking the medicine 5 months before. So what is your advice? And is there any change in the formulation or whatever towards making it like a class of IgG, which probably not crossing the placenta?
Very, very interesting questions. So in regards to your first comment, I agree with you. And that's part of the clinician's problem, in the sense that what we call migraine are probably different types of biological diseases, so biologically driven diseases. And it is clear that for now we have found that one group of this, what we call migraine, is CGRP dependent or very much dependent. But it doesn't explain the whole story. That's why we are not helping everyone. And I always, when I have my patient visits, I always tell them, well, migraine is a lifelong disorder, but the way migraine will express in your life, I mean, the symptoms that you will have will change with time. And probably these changes in time, as you are more or less mentioning, are related to how your biology actually changes, during time. But as I said, it is also very clear in my mind that if you don't control the problem appropriately, it scales up. And we see that all day. I mean, we see that a group of patients, and we still don't have, for me, the future perfect biomarker would be to be able to see already when you are 13 or 14, what is the risk of you becoming a chronic migraine patient. Because it is true, some patients maybe might have one attack per year and that's it. And that's not a problem. But they usually don't come to your clinic. I mean, they just take care of their lives. Or they come once maybe and never again. But there is a group of patients, and that is an important percentage that we would have to control, that have a risk, if not treated appropriately, to develop a high frequent and chronic migraine, which is very burdensome for them. I don't want to have the whole stage. Do you want to answer the acute treatment maybe question, or do you want me to go ahead?
You can go ahead because I think Dr. Sheikh want to.
Okay.
What was the question quickly?
Acute treatment, yeah, I remember. Pregnancy and acute, yeah.
Yeah.
So acute, you can use anything. I don't think you can use NSAIDs, anti-inflammatories, of course. You can use triptans, no problem. And you can use also another CGRP if you want as an add-on. Again, we don't have the biomarker that will tell you that this is such a CGRP patient. Go only for CGRP because that's what is, the main problem, which actually shows that even if you have partial control of CGRP, there are still attacks, and as attacks are hurting. And maybe because it's not the only molecule, but for some it is very important. And we are realizing that you can do add-on with a GPANT on top of an anti-CGRP antibody, and it could also be useful and work for patients. But if you ask me, I usually use the mix of triptans and NSAIDs. What do I do in my clinic? I treat my patients acutely, teaching them to put in the mix a triptan with an anti-inflammatory, and usually that works. When they are treated appropriately, sometimes only with an anti-inflammatory, it also works. It's a bit milder, and with that, they are happy. They actually come back and tell me, Patricia, now I just take an anti-inflammatory. I don't even need a triptan. But you could recommend. I mean, I don't think it's something bad for the patient to be on, let's say, galcanezumab and on top of it with a triptan. I mean, you could be able to do that for sure. In relation to pregnancy, of course, yes, we treat a lot of women who are in their pregnancy years, in their fertility years, and so on. All of these anti-CGRP antibodies can be stopped the day that you know you're pregnant. They are very large molecules. They don't cross the placental barrier until month 4. So in 4 months, that's a half-life. I mean, this is the life of the drug. The drug will have worn down. We published also our experience with 6 pregnant women that we've had that have gotten pregnant when they were on treatment, that stopped it when they found out that they were pregnant, usually it's after 15 days after, being pregnant. And for now, there were no extraordinary, problems. All of our data together with other data from pregnancies that is happening around the world go to this VG database. And for now, this vigilant database that is created around pregnancies seems to be okay. So I don't think you have to do, really, in my mind, nothing special. Just tell them to please stop as soon as they get pregnant or know they're pregnant. If they're preparing pregnancy, I mean, it's already known, they want to, you can also stop it if you want before. I mean, why not? But the idea here is actually that large molecules perhaps are even safer than smaller ones. You know what I mean? Because small goes through. Large doesn't go through. As soon as you get pregnant, you can stop the treatment. If you feel better not doing it ahead of time, then it should be 4 months before starting to get pregnant. But that, for some women, is very hard to tolerate because of anxiety and thinking that they're going to have a lot of migraine. What about pregnancy? During pregnancy, first term, some migraine patients have a lot of migraine or can have a lot of migraine during the first term. Usually second and third term are a bit better. It's a natural treatment almost. But that also doesn't always happen. So then you have to think of what to do in the second and third term. We could go on with that question, but maybe it's too long.
Yeah, just quick comment before, because this is one of the common question we get about pregnancy, and also the other question also from the online people is for how long should we use? But quick question, what I've
How
started to
long, yeah.
notice in terms of pregnancy, especially over the last 2 years, it seems there's a trend that the OB physicians, obstetrician, they started to be more aware about migraine and the impact of migraine during pregnancy if the patient continued to have, and even patient actually, some of them, especially the one who had miscarriage or abortion, they started to link. This might be because I was having bad migraine, and it's actually stimulating me to think about it. I think there might be some study. I'm not sure if it's how strong the
Well,
evidence.
for example, we are just sending off to publish our cohort of. So I work in a large hospital. We have a big gynecology department, and we studied the risk of having preeclampsia if you have migraine. Talking about things, and it's higher. So what I mean by that is that migraine is a true cardiovascular risk factor, and it increases the risk of certain things happening in pregnancy, but not.
Yeah. So, I mean, in the past and still until, I mean, this moment, we always say when you get pregnant, you have to stop all preventive treatment. And we tell but nowadays I start to see the OB tell the patient, no, continue. Like they keep them on propranolol, they keep them on amitriptyline. I was surprised. So, and part of it, I think they are starting to realize, and I'm in communication with them, why they think about that. They're probably seeing more kind of safer outcome keeping patient on these treatment compare like 4 or 5 years ago, we will stop all the treatments. So I think the same thing might apply for CGRP related or targeted therapies that maybe there is no need. I remember in the past when we launched Emgality, there's also a question, and I was puzzled that everyone's saying you have to stop the medication 8 months before or 6 months. They multiply things, and I found it really not practical to tell patients who's having a lot of migraine and they are not sure if they're going to get pregnant or not. But I'm happy to hear, and this is the reason why, Patricia, I want you to answer that so they can hear from you, not from me, that there is consistency in the answer, that there's still no data to say it's better to educate the patient, try to stop it earlier before if you are planning to get pregnant. But I wouldn't stop it or ask a patient to stop it and they go into severe migraine and then
Yeah, it's worse.
and so on. So
It's worse.
yeah,
Yeah, there's more risk probably of many things.
I agree. So for how long? So this is another popular question. Every meeting we have the same question, the pregnancy, and so we keep repeating the answer, which is good. So and especially years by years we have more knowledge. So from your experience, Dr. Patricia, how long would you keep CGI, or what is your approach?
Yeah, I think it's a personal approach. I don't think one has the whole answer. I usually so I don't stop treatment for patients who have more than 4 days of migraine per month, which means that let's say that the patient was not lucky enough to get to my clinic until they have 20 migraine days per month. So they go from 20 and they improve, let's say, a 60%, which is good. They go, as I was saying, down to 8 days of migraine. I don't stop treatment. I've been treating patients constantly and ongoing for the last 5 years. So I would say don't stop if you don't have less than 4 migraine days per month. When they have 2, 3, 1 day of migraine, sometimes 0, I don't stop the first month. I wait 3 to 6 months. And after 6 months, I start saying, why don't we try and stop? Maybe you're in a better controlled moment of the disease and we can stop it. And that's what we are doing. We actually will also publish this data now. I mean, it's sent off also, that shows kind of this cycle that we are doing as a clinic to show what happens with patients when you stop. If you stop too soon, they rebound immediately. If you do what I'm more or less saying, there are chances that the patient will stay some months, or for now, the follow-up has been for months, sometimes a year. It seems, though, that the patient will end up kind of going back to where they were. The thing is that now they know the drug exists and they come asking for it a bit sooner. They won't wait until they have 10 or 15 days. But it does seem that, as I was saying, there's a risk for certain patients of becoming more chronic or more frequent than others. And in those, I think that the drug might be needed for long periods of their lives.
So sometimes when we try to explain it to other physicians, other specialists, decision makers, we tell them. So they say, for how long you'll keep this treatment for migraine patient? I'll tell, okay, you tell me for diabetes patient, for how long you'll keep this treatment?
For life.
Yeah, or hypertension. So especially when they become a little bit difficult, and I tell them this. So for how long you will do this? So and this is what I have learned in medical school. As one of the professor was telling us, there is no cure in medicine except in infectious disease or oncology. But otherwise, all the diseases they are chronic. Hopefully, yeah, we'll have a cure for everything. But we have to be realistic, especially if there is no reason to stop the treatment. I see sometimes physicians are very anxious. We need to stop it. Why you need to stop it? I mean, patients are suffering. There is consequences. Unless if the patient is mentioning clear side effects or there is a clear complication. But otherwise, we have to weigh the benefit and the risk factor. But definitely, this is a very important question. For how long should we keep the treatment? Our patients are improving. What is the long-term outcome? And also safety. For the online, I don't see any other question. We've addressed both of them. Do you have? Yes.
Thank you, Dr. Batista, for this informative lecture. I would like to ask you, when would you consider the failure for response for CGRP? After how many months, like 3 or 6 months? The second thing is, would you recommend switching between different CGRPs if the patient did not give the optimum response for like galcanezumab? Would you recommend trying garadacimab, for example, or others? I would like to know your opinion on that.
Yeah, very good questions. Thank you for asking them and being interested. Yeah, so what do I consider a patient who does not respond, and after how much time? I usually give them 6 months. 6 months, because yes, I mean, what are the, if that doesn't work, what other options do I have? So I don't try to rush to make that decision. I just think, okay, I would say probably if the amount of improvement is zero, really zero in the first 3 months, the chances of improving at 6 months or 9 or 12 months are very low. There is an Italian paper written that there are some patients that it takes them 12 months to improve. I'm not sure. I mean, perhaps that's what is happening, but I think it's quite reasonable to try and wait 6 months and see, whether the patient is improving. The other thing, remember always with this type of therapies, because it's in your also interest, to ask for the headache diary. If the patient comes into your clinic on a bad day, they're going to see everything dark, which means that their explanation of how things are going will not be probably too accurate. I highly recommend headache diaries with the new therapies because they are costly, and you really want to make sure if it's working or not. The other very important thing is to consider other aspects of the improvement. So what do I mean? Yes, headache days, but sometimes some patients are improving a lot in intensity. They tell you, now I can have a life, even if there is kind of this background noise still. They have this kind of, you would say, tension, still headache. As he was mentioning, there's many types of patients, and we don't really know, what we are calling migraine. And for some, you really take away the migraine-like days, but some patients keep on having the headache days. So you have to really kind of be careful of what you are considering a resistant or refractory patient to the treatment, and try to analyze what parts of the problem are not being resolved or solved. Because some patients are improving, but they're not improving maybe so clearly as you would want to. And we consider a refractory patient when they don't improve, or they improve less than 30%. So I would say 30% or less probably is not, good enough. And patients usually tell you, my patients at least tell me, I don't think I want to continue with this treatment. So they actually, it's not me stopping. Sometimes it's them that are stopping themselves in a way. So the only thing that I sometimes try to do is to let them kind of think twice before we stop to see clearly whether if it's a zero response or if there is a mild, moderate or good response with the treatment. And then in regards to switching, yes, I switch. I do switch. There is not super clear, I would say, trials around it, but from this TRIUMPH data and from the PEARL, which is the real-world fremanezumab, also real-world study, we are seeing more or less that you, with switching the antibody, you can save, you can, kind of rescue 30% of patients. So these treatments look alike, but they're not alike. I mean, you even see it in the graph. They're not exactly alike. The immunoglobulin is different. So the protein that actually carries the drug, what they are blocking is different. The weight of the drug is different. I mean, the drugs are mildly different. One gives, side effects which are different. I mean, they're not exactly the same. So probably, we are seeing that for some patients by switching, we really get to, we get a better response. I have the case of one male. He responded very nicely, a full year, 12 months. Suddenly at 12 months, he stopped responding to this anti-CGRP. He was devastated because he thought, wow, I thought this would be kind of a forever drug. So it took me a while to convince him, let's try, because of course he had tried everything before. Very chronic migraine type of patient. So we switched to another antibody after convincing, it took me 3 months. He stopped and said, no, I want to forget this. After 3 months, we started with another antibody and it worked. And now he's happy and he's been on the second antibody. He's been for 4 or 5 years. Since the beginning, yeah. He was one of my first patients in the trials, so very early. So that happens, that can happen. And the other thing that I do, if not, is I combine with Botox. So I do polytherapy, or you combine sometimes with a drug that allows them to sleep, which is a very important trigger. Being tired is a very important trigger of migraine. So you then try to analyze, as he was saying, patient by patient, depending on age, comorbidities, and other things, whether if something else might be playing a role. For example, blood pressure, if you're older, is very important. If you don't control blood pressure, you're going to have migraine even if you give them anti-CGRP therapy. So there's many different things that are surrounding migraine that you need to control sometimes in order to get an excellent response.
Great, thank you very much, Tricia. I think we have just a few moments because I know people are leaving for the lunch. But just a quick question as we are talking about Emgality. Here in the room, have you used Emgality? And I know most of the physicians have left. Dr. Oshik, have you used Emgality? Probably you, yes. What is your feedback? Yes. Yes. Yeah.
What I will say is not to blame anybody, but this is life, and this is business as well. Things come and go, and the problem is we had many patients on Emgality when it went like for short availability. Many of them changed to other medications, and now many of them are actually, they said we have been better on Emgality and we are bringing them back. But certainly we lost quite a percentage of patients due to problems with availability. My recommendation also is you as providers for the company, you should make a network. As you said, you have to have employ patient educators, patient communicators, because these people, they maintain the confidence in the product. And also, if there's a shortage in one firm or one pharmacy, they will probably get it for them. Or even if it's not available in the country, you can bring it as named patient supply for a short period till you solve the problem. But don't let things just go to zero supply. Thank you.
Yes, yeah, this is one of the issue actually, and even the patient will tell us. I don't want it to happen again because this actually indicates it's a very good medicine, and they depend on it, they rely on it. But yes, the supply issue, I know it's a different story, but nowadays it's available. It's interesting. Emgality has been one of the consistent medication. We don't have fremanezumab here, and I know. using monoclonal antibodies binding to the ligand is we prefer to start with them nowadays. I know some of them now it's not as used as previously, but yeah, it's one of the consistent medicine, and it's still available for patients. Patients benefit from it. Okay, I think I don't want to take any more moment, so I'd like to thank everyone for attending this session. Thank you very much. Thank you for your time. Special thanks to Patricia for coming here and enlightening us with the new research and insights. I think we're going to have a group photo here. If we can ask everyone, to come to the stage. We'll take a quick. Let's round of applause. Take a quick photo, and then after that, hopefully, we can catch the lunch.